Well, thank you very much, Dr. Wallace, for that very kind introduction. I feel like an interruption. You were having such a great discussion, and I had a chance to witness almost a half an hour of it, and I'm really pleased that I did. It's great to be here. I've been away from home since Wednesday, so I'm a little worn, but I'm still standing. I was out in San Francisco and at Berkeley Wednesday and Thursday for the Public Health Hero celebration, and I came in here last night, and I'm really pleased to be a part of this conference for many reasons. I looked at your speakers list and those who have come before me, and while I realize that you really don't need me, I'm honored that you asked me to come anyway. And so I'm going to try to engage you for a few minutes with some ideas, but I hope I can leave adequate time for questions and comments, because I think that's the most important thing that we can do. I have to tell you, this is a very special year for me. I had a conference call with former Surgeons General the other day. We were preparing for the memorial for Dr. C. Everett Koop, who passed 2 weeks ago. But at the beginning of the meeting, I told them that this was a special year for me in a lot of ways. It was February 28, and something very special happened February 28, 1913, 100 years ago. Anna Curry was born. She was the 16th of 17 children. Then she went on to have 10 children of her own, one adopted. She never finished elementary school, but most people would argue that if it were not for her, I certainly wouldn't have survived childhood, because back in the backwoods of Anniston, Alabama, and in Anniston, Alabama generally during that time, and I know that was a long time ago, but back in that time, when black children became ill, they usually died at home, and a lot of them died at home. My parents had lost a child a year before, and I came down with whooping cough and pneumonia at the age of 2, and there was one black physician in those areas at that time, and that was Dr. Jackson. And somehow my dad convinced him to come out to the farm on his off day to see if there was anything he could do for me. And Dr. Jackson, according to the story, and my sister just refreshed me with the story the other day, spent all day there working with me. But when he left, he warned my parents that he didn't expect me to live throughout the week. My mother refused to accept that. She was determined. And according to my sister, she would stay up all night, and if I stopped breathing, she would breathe for me. I don't know how she learned to do that, but she did. And I survived. Well, my mother told me that story almost every day, so that by the time I was 5 years old, the one thing I wanted to do was to meet Dr. Jackson. So my parents promised me that for my 6th birthday, they would take me to town to meet Dr. Jackson. Going to town was a big thing then. I never met him. He died that year of a stroke. He was 54 years old, and he died when he died of a stroke, so I never got a chance to meet him. But by the time I was 6 years old, I was telling everybody that I was going to be a doctor like Dr. Jackson. In truth, I didn't know what I was talking about. Nobody in my family had finished high school. But I have to tell you that I was as certain of that as I have been of anything in my life, that I was going to somehow become a doctor, and I was going to make a difference for people who had the kind of experience that we were having in terms of access to quality health care. And that's driven me until this day. That commitment, that concern about making a difference for people who are often left out, that drove me in releasing Healthy People 2010 and the goal of eliminating disparities in health. Drives me as I work today throughout the world on social determinants of health. So I hope you understand why this is a special year for me. It would have been the 100th birthday of Anna Curry Satcher. She died on the day that it was announced that I was going to be director of the CDC. So she had a chance to see a lot of things. I want to talk briefly about targeting the social determinants of health. There's a button up here somewhere. Did I miss it? Oh, great, thank you. I got it. Okay. I want to talk briefly about 4 things. One, I do want to talk a little bit, as Dr. Wallace said, about what we're doing at the Morehouse School of Medicine at the Satcher Health Leadership Institute there. I went back to Morehouse when I left government to develop the National Center for Primary Care. They had offered me the presidency, but after having been president of Meharry for 12 years before going into government, I said no to being president at the Morehouse School of Medicine. But I did agree to go back to start the National Center for Primary Care, and did. But 2 years into that, we ran into a crisis. Our president, Jim Gavin, whom some of you know, left abruptly. He was having some problems with the board. And I was asked to step in as interim president. And I was able to say no. I had practiced that. I was able to say no to the board. But then the faculty came to me and said that if I didn't do this, many of them were going to leave. So I agreed to do it. And it was an amazing 2 years for me. In part because, I was much more mature than I had been when I became president of Meharry. So I knew how important it was for me to really develop a leadership team. And so the members of the administrative staff and I would meet for 4 hours every month and just talk about leadership. We would read, books like Good to Great and John Maxwell's work and others, just talking about leadership. And it was a really interesting 2 years. Part of my strategy was that next time we ran into a crisis, I wanted to make sure that I wouldn't be the one they were pointing to. But it was a great experience. And when it was over, the Board of Trustees voted to establish the Satcher Health Leadership Institute. And Bill and Camille Cosby endowed it with $3 million. And so that's how we started this institute. The mission of our institute centers around the whole area of disparities in health, and yet our approach to it, because you could argue that the Morehouse School of Medicine's mission is about eliminating disparities in health, but our institute is to develop a diverse group of leaders who will not be just committed to reducing and ultimately eliminating disparities in health, but who will be prepared in terms of innovative strategies, in terms of influencing and informing policy. They will be prepared. So that's what we're about. That photo is there for a reason. This was some of you involved with the National Medical Association. I think this was the 100th anniversary celebration that took place in Atlanta, and that was the first time that we started a program really for getting children to be more physically active. So this was the walk for children. And so, does anybody know who that person is who's standing next to me? Well, you should. That's Shirley Franklin. She was mayor of Atlanta, often ranked one of the top mayors in the world, top 5 at one point. A very special person. We all complain about kids dropping out of school and not going to college. When Shirley Franklin was mayor, she met with every student that was either going to high school or that was going to the point of going to college, and to find out what their plans were. And if they weren't planning to stay in school or to go to college, she tried to convince them that they should. I never heard of a mayor doing that before, but that's the kind of person Shirley Franklin is. So she was with me on that walk. In 1988, the Institute of Medicine did a report called The Future of Public Health. And they made this statement that today the need for leaders is too great to leave their emergence to chance alone. And that's what we buy into. We believe that you can't just talk about the need for leadership, that we really need to get together and do something about it. They also, I don't know how you define public health, because there are different definitions floating around, but in that report, the Institute of Medicine said that public health is the collective efforts of a society to create the conditions in which people can be healthy. I mean, just think about that. It is the collective efforts of a society to create the conditions in which people can be healthy. Now, I thought we were doing something great when, as a member of the World Health Organization Commission, we talked about social determinants and we defined them. But the fact of the matter is, you can't do much better than that to incorporate the social determinants of health into public health. It is the collective efforts of a society to create the conditions in which people can be healthy. Now, we have a few leadership lessons at the Satcher Leadership Institute, and I'll just take a minute because I think it's relevant to this conference, what we think are part of our leadership strategy. And let me say, the first principle that starts with me is that we're all students. And, I've had a lot of opportunities to lead in this country over the last 35 to 40 years. And many of the people who come to us see me as an expert in leadership. So the first thing we have to get clear about is that I'm not an expert in leadership, but I am an excellent student of leadership. I have studied it, I continue to study it, and I learn something new every day. So I happen to believe that leadership is a learning experience, and that once leaders stop learning, whether it is about the significance of hip-hop, and I'm learning every day, once leaders stop learning, they stop leading. You can't lead when things are going beyond you, so you got to keep learning. So that's our philosophy, is that everybody teaches and everybody learns. And it's been interesting because as we work with the community around us, and we've had some real success and, as well as some struggles, but I think what brings us together is this attitude that we're all learning, and they have a lot they can teach us, and we plan to learn. And we hope that we have something that we can teach them. So it's a learning experience that we have when we meet with the mothers or single parents in our community program called Smart and Secure Children. But we believe that leadership responds to opportunities, to challenges, to crises. And we have our share of all of them. Let me tell you. I have been through so many strategic plans in my career that sometimes I never want to see another strategic plan again. And I know how important that is. But let me tell you, there are times when you just have to respond, right? You've got to be ready to respond. People in New Orleans were not ready for Hurricane Katrina. How could you be? But we had to respond. And when people come together and respond to those kinds of challenges and crises, leadership comes to the forefront. But now, that's not the only thing we have to respond to. We have a lot of opportunities to respond to, and it's almost as tragic not to respond to opportunities, right, as it is to not be able to respond to challenges and crises. Because, they all come to us. Opportunities that we have, hip-hop is an opportunity. But how do you make it an opportunity? How do you take advantage of that opportunity? Leadership is a team sport. We really believe that. I made a lot of mistakes in my leadership career. And some of them are too embarrassing for me to share with you. But, there are a lot of them, but I remember when I went to Morehouse president, I was 41 years old. I really was really proud of myself for having risen to that leadership position. I made a lot of mistakes because I didn't appreciate the fact at first that this is a team sport. Leadership is not about me. It's not about individuals. And once I get caught up in me, I'm getting ready for the big fall. And that's true today. It's a team sport. And one of the biggest challenges of leadership, of course, is team development. But I also want to say to you, and I said this at Berkeley 2 nights ago, I shared the Public Health Leadership Award with Mike McGinnis. And I don't know how many of you have heard the name Mike McGinnis. Anybody? He hasn't been in a lot of top positions, so you'd almost have to be in public health. But it was Mike McGinnis and Bill Foege who wrote the paper about determinants of health in 1993 in the New England Journal of Medicine. It was about what determines how healthy you're going to be. And they listed 4 areas, genetics, biology, right? Access to quality health care, environment, and then behavior. And what surprised a lot of people was that they concluded that health care accounted for only about 10 to 15% of the variation in health outcome. That behavior accounted for about 40%. It was, at that time, it was sort of revolutionary in terms of the way we thought about health. And of course now we know that even overriding all of those things are the social determinants of health. Michael McGinnis was not in a leadership position when he did that, and a lot of other things he did because you don't have to be in a position to provide leadership. You just have to have a commitment, and you have to have something to offer to the direction or the way forward. So I tell students this every day, that don't wait until you get into a position to exert leadership. And because I have students coming to me when they first come to school, and even though they may not have passed basic courses, they want to know, how do you become Surgeon General? And this is the way they say it: how did you plan to become Surgeon General? And they're always disappointed when I tell them, I didn't plan to become Surgeon General. I have some things that I'm concerned about that drive me, and I try to take advantage of every opportunity I can to implement those things. And what I have found is that if you do your job well, people find you. When I was a student at Morehouse, and I graduated from Morehouse College 50 years ago. This is my golden anniversary year. I used to think that people coming back for the 50th anniversary were really old. But this is my 50th anniversary year. Dr. Mays, who was president at Morehouse at the time, and he was a minister, he would come to chapel every Tuesday morning. He did it when Martin Luther King Jr. was a student there. He did it when I was a student. And he would talk to the students about life. And what he used to like to say to us was, he said that whatever you decide to do in life, you ought to strive to do it so well that nobody living or dead or yet unborn can do it better. That was his philosophy. That was how he charged the Morehouse students. Strive to do whatever you're doing so well that nobody living or dead or yet unborn could do it better. In other words, he was saying, take very seriously the opportunities that you have. Effective leadership, we believe, transforms communities. And community transformation is a major part of the elimination of disparities in health. And sometimes it seems that our communities, all of our communities, need more transformation than before. But effective leadership does, in fact, transform communities. And even though global is not underlined there, leadership requires a global perspective. And I do want to say that I think there's no better example of that than the fact that while we were focusing on disparities in health, because we started that in the World Health Organization looked at that and said, We want to do something on a global basis, and they asked me to join the Commission on Social Determinants of Health. But you know what the goal of the World Health Organization is? It is global health equity. It's the goal, global health equity. And it was that goal that drove the Commission on Social Determinants of Health. How do we reach global health equity? So, and I'm only saying that to say, regardless of your field of study or your concentration, you got to have a global perspective, or else you're going to miss something. You really are going to miss something. They looked at us and our goal of eliminating disparities in health, but they brought to it a global perspective, and they sent us all over the world to develop the report on social determinants of health. My favorite one here, of course, is that leadership is like a relay race. And when I was a student at Morehouse, I ran a little track. Some people underlined little, but I did run track. My favorite event, which I didn't run, was the relay race, because I like to watch the relay race, because that's what life is sort of about. It's about how can we do the best that we can do now, and then make sure that when we pass the baton, the people coming after us have more momentum than we had, more opportunity than we had. So when you look at life as a relay race, and that was another mistake that I made when I went to Meharry. I remember being so critical of the people who came before me. The institution had a lot of problems. I mean, $25 million debt. But as opposed to really appreciating what it took to get to where we were, I spent too much time saying how bad things were when I got there. And leaders tend to do that, and that's a mistake. What you have to do is to really appreciate what came before you, and then try to move forward to a much higher level. If I keep telling you the mistakes I made, you're probably wondering why they invited me here. Well, as Surgeon General, I had the opportunity to release several reports, and the reports of the Surgeon General are based on the best available science. I mean, we get science from the CDC, from NIH, from HRSA, and from all over the country. We get people, experts, to have input. We did that when we did the goal of eliminating health disparities. We already had the objectives and measurable objectives in place. Michael McGinnis was telling the students at Berkeley that he disagreed with me when we were pushing for the goal of eliminating disparities in health. And he said because his perspective was that you don't set goals that you can't reach, or that you know you can reach, and when and how. And then he said it was later that he realized that he was talking about objectives, that goals are aspirational. You know, you got to have, to say that you're going to move toward global health equity, or you're talking about where you plan to be. You don't know all of the ways that it's going to take, all of the things it's going to take to get there, but you're very clear about where you plan to end up. And we were very clear that we wanted to end up not just reducing health disparities, which had been the goal before. We wanted to end up by eliminating them. We didn't apologize for that. And I think we should not apologize for a global goal of health equity. Well, I had the opportunity to release several reports when I was Surgeon General. And when the panel was talking, I was thinking about Cynthia Bennett, her name now I guess is Cynthia Bennett Turner, who was my public affairs director. Cynthia is now pastor of the Dayspring Community Church in Washington. But the influence that she had on my thinking, about a lot of things, I think it's reflected in these reports, and certainly the way in which I communicated them. Now, there are several reports there, and of course you probably remember some of them, like the mental health report was the first ever Surgeon General's report on mental health. So was the oral health report. So was the Surgeon General's call to action to prevent and decrease overweight and obesity. And some of these reports, of course, were successful in starting movements and changing policies. Certainly, the mental health report recommended parity of access to mental health services. And that was 1999 when we released it. It was not until 2008 that President Bush signed legislation that Congress had passed for parity of access to mental health services. And we released the Surgeon General's call to action to prevent and decrease overweight and obesity in 2001. And in 2004, Congress passed the wellness policy. So things happen a little faster around overweight and obesity. And now, of course, the First Lady is announcing that we are seeing a decline in childhood obesity. But if you think about what's happened since that report, then you see why the relay race concept is so important. You have to keep pushing forward in order to reach the goal. So these were the goals of Healthy People 2010. They were to increase years and quality of healthy life, and that's becoming more important every day when so many people are disabled as they get older. People are living longer, but when almost half of the people over 80 are incapacitated mentally, physically, and both, it can be very difficult. In our house, of course, we're very familiar with Alzheimer's disease and its various stages and watching people change and go through those stages. So the goal of increasing the years and quality of healthy life is a very important goal. And the other goal, of course, that we talk a lot about is the goal of eliminating racial and ethnic disparities. When I talk to students at Spelman every year, and it's the first week of school, when they've just come, I keep coming up with ways to try to define disparities. And I think the one I used last year, or year before last, was that there are differences that occur in health by gender, race, or ethnicity, education or income, disability, geographic location, or sexual orientation. Now, I have to confess that when we first released the report, I was thinking primarily about race and ethnicity. And that was the focus, and that has been the major focus. But clearly, when you think about mental health, and you think about the fact that a person with severe mental illness can expect to live 25 years less than the rest of the population, then you realize why mental health is such an important area of health disparities. I think we have the only endowed chair in sexuality and religion in the country. And we're proud of that because we believe that human sexuality and the role that religion plays in our lives are so important that we need to spend more time talking about their relationship. So we were able to get an endowed chair in religion and sexuality, and I believe it's still the only one in the country. You've seen a lot of this data about disparities, and I don't have any intention of dwelling on that. I worry about infant mortality because, that's the risk of a child dying in the first year of life. So many things come together to decide whether or not a child survives that first year of life. So many things come together, and you heard my story, but there are so many different reasons that a child may or may not survive the first year of life. But when all of those things come together, and they include prenatal care, they include nutrition, they include whether or not you're abusing drugs, they include stress and the relationship between the mother and the father, folic acid, all of those things impact whether a child survives the first year of life. And we know how important social determinants are. In fact, Gail Walensky and I had an article in the Journal of Health Affairs after the WHO report in which we basically talked about how nutrition virtually sculpts the developing brain in that first year of life. And we've come to realize how brain development is so critical. We've just come to realize perhaps how important the brain is. We've been working with the NFL, as some of you know now, for about 4 years. We have one of the 7 centers for neurological care where former players can come to be evaluated and receive care if they are having difficulty related to concussions that they suffered while playing. And one of the messages we're trying to get out, and I hope you will help get that message out, is that the brain is the most important organ in the body. I mean, the brain is so important that you ought not to see boxing where you're banging somebody's head as a sport. In fact, the banging of heads can no longer be considered a sport. and that includes in the NFL. It's been a tough message because football players from the time they're in elementary school like head-to-head contact. We got to take, in that sense, we got to take the head out of the game. Not in the sense of thinking, but in the sense that this is nothing to play around with. You know, when people suffer concussions, you're putting them at risk for having dementia later on. Even when the NIOSH did their study, I believe it started back in 1959, it showed even then that dementia was 3 times more common in former football players than in the rest of the population. Now, do I also have to tell you that 70% of the NFL players just happen to be black? 70%? So head-to-head contact, it's true for all of the players, but I just remind you that it's great that, you know, we've been so successful in football, but it's also important for us to realize that we've got to find a way to protect players if we're going to continue to play this game, so that the brain is not the target for the game. And that starts in elementary school. So if you have children playing football, I hope you're talking to the coaches about, and some states now have laws requiring the kind of things that would be necessary to protect the brain. And cardiovascular disease, again, African Americans have the greatest risk of death. And diabetes, of course, with the obesity epidemic. And I'm delighted that there seems to be a changing of the trends in terms of direction. I hope that's true and that it will persist. But even Mississippi, and if you live in Georgia or Alabama, by the way, you appreciate Mississippi because we always said if it were not for Mississippi, we'd be at the bottom in everything. But because Mississippi, you know, they have the highest childhood obesity rate. And even during the period of segregation and discrimination, Mississippi was worse than Alabama, if you can believe that. So, but now what we're hearing, the good news is that Mississippi has done a great job in some ways, and we're now seeing a decline in childhood obesity in Mississippi. This is the study that we did at the Morehouse School of Medicine, and to make a long story short, we asked the question, what if we had eliminated disparities in health in the last century? And we concluded that in the year 2000, in that 1 year alone, if we had eliminated disparities, there would have been 83,500 fewer deaths among African Americans. In that 1 year, 83,500. And you see the various causes, 24,000 from heart disease, 7,000. In some of those areas, we're making progress. You know, obviously, we know that we're seeing fewer deaths from HIV/AIDS, from AIDS. In fact, the total number of deaths from AIDS in 2010, I believe, was like 15,500 for the whole country. But we still have about 50,000 new AIDS infections a year. And the group that's most at risk now, of course, are African Americans, men who have sex with men. And so we've targeted that population, in fact, the whole LGBT population, just in terms of what do we need to do to make sure that not only the messages get to that population, but the resources to deal with this. You know, I remember back when the AIDS epidemic was first recognized. I was president of Meharry. I remember, I guess it was 1983 when the White House sent a team out and they wanted to speak about this disease, and nobody wanted to talk about it. And they were able to come to Meharry and talk about this new disease. But a lot of things have happened since that time in the laboratory, new drugs, and I think the best news in recent years has been that the treatment of AIDS is also prevention. In other words, we now know that if we effectively treat somebody who has AIDS, that it dramatically reduces the risk that they will then spread the virus to somebody else. It's great when treatment and prevention come together. It's great when we can say if we can treat more people, then fewer people will be spreading this disease. Now, the other side of that question is people with AIDS are living longer because of treatment. So it's sort of a double-edged sword. If we can say we can treat people and prevent them from spreading, and yet more people living longer, and if we don't effectively treat them, more people will be spreading the disease. So that's sort of the challenge that we're facing there. We can meet that challenge, but it's very clear what the challenge is. I think this was, without our knowing it, was a very telling observation from that same study. If you see what's happened to black females and how from 1960 to 2000, the mortality ratios, if you compare the death rate for black females and white females, as compared to comparing the death ratios from black males and white males, since 1960, the ratio for black women has gone down. For men, it's gone up. Especially starting around 1980, we saw a dramatic increase in the mortality ratios, black males compared to white males. And when you think about 1980s, a lot of things happened, of course. Certainly a lot. Homicide went up during that period. Crack cocaine came into play. But I think there's something else that's very telling here. I have watched historically black colleges throughout most of my life. And one of the changes that we have seen, of course, going back to the 70s and 80s, was that so many more black women on college campuses than black men. And in many of our schools that are co-ed, it's like 3 to 1 women to men, or sometimes even 5 to 1. That's what we have seen. And so this whole education thing has become much more a thing that black women have taken advantage of than black men. At the same time, we've experienced high dropout rates for young black men and high incarceration rates. In Atlanta, of course, we have a major challenge with school dropout. And, of course, 80% of those people who drop out and don't graduate from high school will be incarcerated by the time they're 30 years of age. So incarceration, education, lack of education, all of these things are reflected in mortality ratios. So this is, I can talk about social determinants from the standpoint of what we found through WHO, but perhaps without recognizing it, this study that we reported in Journal of Health Affairs was really demonstrating what happens when social determinants take over. Now, this is actually under 5 child mortality here. And I want to take this to a global level just for a minute to get to the social determinants. This is not the United States, this is globally. And we have the goal of global health equity. Well, if you begin with sub-Saharan Africa, so a child is born, what's the risk that that child will be dead before 5 years of age? It's 175 out of 1,000. In other words, almost 2 out of 10 is a risk in sub-Saharan Africa that the child will not survive the first 5 years of life. Major issues involved here. Unsafe water is a major issue. Violence, refugee population, a lot of issues come into play. Even malnutrition and hunger, infectious disease, all come into play. South Asia, especially India and other places in South Asia, we see the same thing, more poverty, more malnutrition. And then you get over to the industrialized countries, and I think the United States is about, 8 per 1,000 babies dying by 5 years of age. So it's interesting, if you just looked at that slope, it's an interesting slope. But the interesting thing is, the same slope occurs within countries. And the other thing, of course, is that you can also plot household wealth. And it looks almost identical, right? Within countries, Washington, D.C., I'm sure you've heard this, but we're in New York, right? In Washington, D.C., if you go from one end of Washington to the other on the metro, the life expectancy difference is 17 years. Now, the person who reported that, I believe the first time, was Michael Marmot. I know Charles Murray had input, but Michael Marmot in England, University College of London, who chaired our commission, used Washington, D.C. as an example of how mortality rates changed from one end of the city to the other, and how it was related to income, wealth, and things like that. But as you can see, when we talk about disparities in health, we're talking about within our country, but the slope is the same. And these are determinants of health. And the only thing I want to say about this is, again, this is the access to care, the genetics, the environment, and behavior. And I have preached, of course, that we got to change behavior. So when I was Surgeon General, I came out with the Surgeon General's prescription. It's about being physically active at least 5 days a week, 30 minutes a day. It's about consuming at least 5 servings of fruits and vegetables per day, avoiding toxins like tobacco. It's about responsible sexual behavior. And it's about having a plan to manage stress in your life. Very important. You do have a plan to manage stress. But what we said was that this behavior accounted for almost half of the variation in health outcomes, so we had to get a handle on it. But you know, social determinants of health impacts all of those. Physicians decide on where they're going to be practiced, often, most of the time, by the socioeconomic status of that community, by the wealth of that community. And they justify that. And then there are other communities that will have no access to care. You know, it's hard to get people to practice there. And that's true, especially in our country, because of the way we pay for health care. It's discriminatory, and so it shouldn't be surprising that access to quality health care is so much lower in some areas. But the thing that we also have to remember, and I'm sure you've discussed, is that whether or not people are physically active or whether or not people consume fruits and vegetables is also determined by the socioeconomic status of that community. And there are many communities, including one around us in Atlanta, where there's no easy access to a grocery store with fresh fruits and vegetables. And there are communities where it's not safe to get up and walk or jog in the morning. So the chances of somebody doing that will vary by the socioeconomic status. So this is the old diagram that Mike McGinnis and Fagin came up with. We actually did the diagram. We took their results and put it in a diagram showing how these factors related to each other. If you had a chance to look at our book on multicultural health and health disparities, there's a chapter in that book by Frances Dunstan, who was the chair of pediatrics at Morehouse. But she tries to put these community factors in perspective. And just think about these, and I won't dwell on them, but these very important factors that affect the health of people in our communities, especially urban communities. Violence, I just talked about how it affects behavior. Poverty, which is a broad term that incorporates wealth and a lot of other things. Substandard housing, alcohol or drug addiction, environmental toxins. Now there's a book on environmental racism, about where do we locate hazardous waste sites, substandard education. All of these things impact poor health outcomes. And this was in the book in 2006, by the way, and we didn't do our report from the World Health Organization until 2009. So how have we changed as a country when it comes to the goal of eliminating disparities in health? I was really worried that Healthy People 2020 would not continue the goal of eliminating disparities in health, because we had suffered through 8 years during the Bush administration, and I was in the first year of those 8, because my last year was in that. But we had suffered through 8 years in which over 10 million people had become uninsured during that time. And so a lot of things had happened to take us in the opposite direction in terms of eliminating disparities. But the people who put together the goal of Healthy People 2020, I thought did a great job. They continued to focus on quality of life, but then they said achieve health equity, eliminate disparities, and improve the health of all groups. So, they tried to incorporate both the WHO, focus on social determinants, as well as maintaining the goal of eliminating disparities. They explicitly talked about social and physical environments and the quality of life issues. The social determinants of health are important. They're the conditions in which people are born, grow, live, and work, They're shaped by the distribution of money, power, and resources at the global, national, and local level. And if you're going to change the social determinants of health, you often have to have policy change. It is all relative. I heard this story the other day, and you may have heard it, but I think David Jeremiah told a story about the guy who went to the funeral of his brother. And I have 5 brothers. But there were these 2 brothers, and they didn't get along that well. One of them did quite well. In fact, he was wealthy. And his brother, John was his name, his brother Eli died. And he went to his funeral. And he had mixed feelings about it. And number one, he felt guilty that he hadn't been closer to his brother. So he decided that he was going to do something. So he met with the preacher who was going to preach the funeral. And he said, I will give you $100,000 if you will say that my brother was a saint. And the preacher said, are you kidding? Your brother was, he was not a saint, and he didn't support the church. And John said, I will give you $100,000 if you get up at the funeral and say that Eli was a saint. And the pastor told me he'd have to think about that. So the other funeral, they got back together, and John had written out the check. Here it is, $100,000. Well, the preacher took it. He gave it to his treasurer and told him to deposit it. John was excited. He sat on the front row. If you think about what this meant, he was finally going to do something great for his brother, but also he was going to be able to make a point to his wife. You can't trust these ministers, money. So he had 2 goals. So he sat there on the front seat of the church, and the minister said, as I rise to preach the funeral of Eli, I have to say to you that Eli was a scoundrel. He didn't support the church. He cheated on his wife. He was an abuser. And I just have to tell you, he was a scoundrel. But compared to his brother, he was a saint. He was a saint. Well, it is all compared to what? Well, I want to close just briefly say that the Affordable Care Act, which a lot of people are trying to disentangle in Washington and throughout the country, the Affordable Care Act actually moves us forward in terms of eliminating disparities in health. It moves us forward, I think, in 3 ways. The real focus on primary care and incentivizing primary care is very important. Providing quality of care measures so that physicians are reimbursed not by how many times they see a patient, but by the outcome of that care moves us forward. All of these things that are listed here, I think, are important to eliminating disparities in health. But I'm most excited about the prevention agenda. And the prevention agenda was put together by the Surgeon General and a council that had representatives from all of the departments in government. So not just Department of Health and Human Services, but education, justice, all of commerce, all of the departments participated for a year, and they came up with a prevention agenda. In other words, if you're going to talk about preventing injuries, then you had to talk about what justice was going to do to try to help reduce violence or transportation. And if you haven't read the prevention agenda, which the Surgeon General Virginia Benjamin put out, I recommend it. Because I want you to know that as people try to get rid of the Affordable Care Act, in my opinion, the Affordable Care Act is critical to our continuing to move forward to eliminate disparities in health. And we ought to be talking very loud about that. So I just wanted to make that clear. I think it's critical. So let me close by saying that we believe at the Satcher Leadership Institute that in order to eliminate disparities in health, we need leaders who first care enough, we need leaders who know enough, will do enough, and leaders who will persist until the job is done. We need you. Thank you. I meant to leave more time for questions, so I hope we have a few minutes.
Okay. Any questions? 5 minutes. Here you go.
Thank you so much for your talk. I have a question, actually just hoping to get your recommendations. I'm working with an organization who received the Community Transformation Grant. So we've been working to support organizations like, or health insurance companies and providers in coming up with ideas to create environmental change inside of the opportunities that are presented for the through the Affordable Care Act. Mm-hmm. And I'm wondering if you guys have thought about this or if you have any recommendations to offer.
If we've thought about what specifically?
Opportunities for health insurance companies and providers to create environmental change inside of because of the opportunities that have come out of the Affordable Care Act.
Yeah, in fact, I met with Kaiser Permanente for 2 hours when I was out in California about their expanded role, and they call it total health. And so Kaiser Permanente, which is ahead of most of the rest of us when it comes to health care, that's not profit motive, because if you go back to 1940s or World War I, Kaiser was started, to take care of people, not just coming back from the war, but employees and things like that. So I think their approach is that they've got to find a way to improve the community as a whole if they're going to engage in total health. And so looking at ways they can invest, including working with schools. Now, we've been really pushing schools to engage in physical education K through 12, to make sure that every child has a breakfast when schools start. A lot of these schools need a lot of help. And organizations like Kaiser Permanente can really invest in those kinds of programs and help schools do it. Just one example. But I think this whole commitment to improving the healthy environment of a community, and we had a fellow, in fact, she graduated from Berkeley and then came into our institute. Some of you know her name, LeConte Deal, and her whole focus of her work has been on place-based health, the environment, and luckily she stayed with us after she finished the program. But I think insurance companies, health providers generally are really now beginning to look for ways that they can, in fact, improve the environment. But, the key is, are they incentivized to do it? If you're going to make all of your money from the number of patients you see and how often you see them, you're not going to worry much about their being healthy out in the community. So we've got to, and that's what the Affordable Care Act attempts to do. It attempts to move us in the direction of health and not just focusing on disease. And that's where community comes
in. This is going to have to be the last question.
Thank you so much for your talk. I had a question. I'm interested to know about different models of care outside of the United States, like Cuba and Canada, and what we can learn from their ways of reducing health disparities. I'm more familiar with the Cuban system and the community-based healthcare where they have CDRs, which are these, units within the community that deal with health. So just basically, if you have any suggestions and if you've done any research about that.
Well, yeah, I'm certainly familiar with Cuba, and our team went to Iran to look at their system, and I know that we have this very difficult relationship with the Iranians, but they were, by the way, the first to eradicate smallpox. But what we visited in Iran was these community units where they have people who have the equivalent, of a high school education. They are trained to provide vaccines, so they give immunizations. And of course, so there's one for every 1,500 population. Then they feed into larger centers. But it's a community-based approach of making sure that everybody has access to health care. And I believe their immunization rates were 97%. And I know Cuba, the focus is on primary care, the focus is on community, what can you do to keep people healthy? I think the biggest difference, however, in our system and those systems relates to incentives. Our system, money is very much the incentive. You make money in our system by treating diseases. And so we are always treating 75% of Medicare, what we pay for in Medicare, are preventable diseases. But our system is set up to target diseases and treat them much more so than it is to prevent them. Who gets paid for prevention? Just ask you that question. And again, well, somebody, but you don't get much pay. Mike McGinnis and I did that study when I was in government, and 3% of the budget at that time of our health system, now we spend, what, $2.8 trillion last year? 3% for population-based prevention. So it's very clear where our priorities are. That's why Obama is in trouble with Affordable Care, because the Affordable Care Act attempts to change that. And don't let people fool you. You know, people are after that because it's a dramatic change. It focuses on health much more than we've ever done before in this country. And not a lot of people are going to get rich in the health system as in the past, but many more people are going to get health care and be healthy. I want to make that very clear. When they're playing politics with the Affordable Care Act, they're playing politics with the goal of eliminating disparities in health. And they're playing politics with a lot of people's health. And I mean, Georgia is one of the states that's, for example, refusing to expand Medicaid. And so we've got some big fights on our hand. But there's a lot at stake. I'm not saying the Affordable Care Act is perfect. I mean, actually, obviously, if I had written it, it would have gone much further in terms of prevention and community. But I believe that it moves us forward significantly, and we ought to keep, it brings theoretically 32 million uninsured people into the health system in a way that's affordable. One thing that not many people are talking about is that while we've been having all of these arguments about the Affordable Care Act, and Congress is now threatening to eliminate it, the health care costs have been going down. You don't hear much about that, but it's going down in great part because of changes that are taking place in incentives. And so keep that in mind. Thank you.
Okay. Don't leave. You can put your things down. Tom, can you get my iPad? All right. Well, I guess we are just so full of gratitude, not only for you and for your presentation and for all that you've done across your career, but we're also now enlightened as to why we should be very grateful to your mother. We know the power of storytelling. So when we go back to the power of hip-hop and narrative, we need to remember how a mother telling a child a story over and over again has led to a revolution in this country when it comes to the health of those who have been most negatively impacted by disparities. And now we're also grateful to Dr. Jackson. But we're going to continue to remember your coming here and delivering this keynote in future years, because we are going to inaugurate an award in your name that we will give in future years. And so you were the first recipient. Let's move into the light. Yes. As part of the celebration of the 5th Annual Health Disparities Conference at Teachers College, Columbia University, and 10th Anniversary Celebration of the Research Group on Disparities in Health, David Satcher, MD, Ph.D., is awarded the year 2013 inaugural Dr. David Satcher Leadership in Health Disparities Research Award for outstanding service to bring about health equity and social justice for all. Teachers College, Columbia University. Thank you so much.
Let me just say that I am tremendously, deeply honored. So thank you very much, and I hope that can be, in fact, an inspiration, motivation to people who can do much more than I have done. Thank you.
Okay. So, housekeeping. We